afternoon, everyone, and welcome. I am excited to introduce our two panelists. First, we've got Dr. Michelle Dodds, who has been a nurse for 25 years, a nurse practitioner for 20, and just recently, she completed her doctoral degree. Early on, her experience working with rural communities, visiting at-risk populations in their homes, showed her just how important resiliency is to taking care of people in crisis. When someone doesn't have food or secure shelter, healthcare becomes so much more than treating one issue. Dr. Dodds hasn't lost sight of this early lesson, and she treats every patient holistically with understanding that resiliency and operational medicine requires that we see patients as people. Thank you for being here, Dr. Dodds. Next, we have Mr. Jeff Graley, who is a veteran of the Air Force and is also the president of Mile2, a unique software company that has a strong foundation in cognitive systems engineering, which is a deep dive approach to solving problems within a larger system, which includes both humans and machines. Jeff understands the importance of partnerships. Before developing technological solutions, his team seeks to understand the practitioner's work in the field. And it seems that his approach is working because over the past 5 years, Mile2 has grown from 2 people in 2015 to a team of more than 30, and they are looking to hire more than 10 additional team members. So thank you both of you for being here this afternoon.
So that's funny, the data moves fast. So we're over 100 now.
Oh, wow. Okay, I was a little misinformed.
We crossed 100, so.
Congratulations. Thank you for correcting me on that. Okay, so let's just get right into the question. So resilience is defined as the capacity to recover quickly from difficulties. When we're talking about medical personnel performance in crisis situations, we're talking about preparing for the unthinkable, for the things that we can't anticipate. So what strategies, technologies, and partnerships do you believe are important to increase medical professional effectiveness in these high stress situations? Who wants to kick us off?
I will.
Thank you, Dr. Dodds.
Well, strategies important to increase professional effectiveness includes the ability really to rapidly assess the areas of need in crisis to support employee performance, their physical health, their emotional health, both throughout the stress and including kind of the debriefing afterwards to manage the stress. I have found it imperative to ask myself in those situations what I can do personally to decrease stress. How can I contribute to those situations with my coworkers in a positive way? How can I support them in the middle of crisis? What can I do to reduce the stress of the crisis? We can often find that by doing in crisis, we can help decrease the stress. I see a lot of looking at situations analytically, which is very important and needed, but we also need to recognize that with analysis, the provision of action to go with that speaks volumes to those around us in the middle of the crisis. And really analysis without action is just word and thought.
Yeah, and to build off of that, like what Dr. Dodd said, she started pointing out things like, how do you support attention, right? When you talk about complexity and a lot of movement, a lot of communication, you need to support attention effectively for folks to be able to be effective in those situations. These kind of problems I like to flip on their head and start to talk about brittleness, which is the opposite of resiliency. So if you're talking about brittleness, how do you support the things that break, like handoffs, attention direction? When everybody wants your attention, nobody gets your attention. People only have so much capacity. So when I start to think about tools and technologies to support that, you need to design them to support those functions. BatDoc, I think I saw Greg Burnett's talking on a later panel. He was one of the guys behind BatDoc. That's a perfect example of there's not enough attention to go around. So how do I centralize information and use representation aiding to be able to direct attention to the most critical cases because you have only so much capacity and throughput from your providers?
Absolutely. And, you know, being on the front lines of patient care, because that's where I'm at. I am working in an academic setting, but I'm pretty much in the clinic most of the time, with patients most of the time. I see, like, during this pandemic, the stress my coworkers have been through, the stress that we have been through, the unintentional COVID exposures that happen, even with all the screening that we do, even before people are at the front door, and what stress that creates and what anxiety that creates. So every time we experience something like that, we have gone back and tried to problem solve. We have a COVID task force here that we work together. And at the beginning, we were meeting a couple times a week. It's pretty much at least a weekly meeting still at this point, because as COVID changes and the science behind it changes and how we treat patients changes, we have to keep changing our response. And so the part of the management of crisis and being resilient is that we have to also be open to, like, continual change on the front lines of understanding. We've got to keep looking at the research. We've got to keep, being flexible and adaptable. And I feel like, personally, for me, I have to be that person. And I'm older. It's hard for some of us older people to change, the challenge of that. But I also realize, to be the example of that, I have to work on that in myself to help reflect that to the others that I work with too.
Yeah, I think that's where design and context matters, right? So when you start to design these systems, people are always the glue. Poorly designed systems, people become the glue. So when you're designing it and you're doing a really good job in the human machine teaming world, you're understanding context, you understand the roles and responsibilities of what the individuals that play in this system or the data in this system, what everybody's role is, and then designing to support those roles. And you actually hit on one of those functions that I didn't mention. One of the super important things when you're doing planning is the ability to replan. Replanning effectively is a sign of a resilient system. So when you're bringing technology to the table, or new processes or new communication methods, we look for, okay, how do you support replanning? And you absolutely nailed it on the head. Those areas where people struggle is handoffs, or this is what we anticipated. Here comes something that was unanticipated. Now, what do we do? How do we be adaptive? And supporting, the core functions that people need, like planning, replanning, attention, direction, those kind of, I keep going back to the same ones because they're so important. If you can support where the energy needs to go, you don't tax your people, which is your greatest resource in a human machine team, in the wrong ways.
So could each of you tell us about an example where you witnessed a partnership or collaboration successfully solve a complex problem related to complex situations?
Sure. We built a cardiovascular risk tool. And this was a situation where, Framingham, Massachusetts, there's a famous model about cardiovascular risk, a longitudinal study that they did. So we were able to go to the literature. So somebody did the work to do this study. We were able to take that, lift those models from the study and put them in a software algorithm and then build designed representation so that people knew how to interact with their data, right? It's telling you about your blood pressure, your age, whether you're smoking or not, do you have other risks like diabetes or other issues? And then it gives you a number. And what good is a number, right? That's kind of like looking at an Excel file and saying, well, that's the important cell. You need to actually have actionable information. So we built a graphical representation so you could see how you could actually impact improving your score, or what your trend was looking like if you just got older and kept doing the same things. But we couldn't have done it without a partner. So we had a partner in this called Asymmetric, and they were really, really good with the back-end data side and the APIs that you needed for open healthcare systems like Fire7. So that was a combination. That's one of those things where a lot of good things came together. Research, people that could work the back-end data structures, and then our ability to design representations that actually aid people to make good decisions from very complex situations.
So, Dr. Dodds, before you answer that question, and I definitely will come back, I'd like to just take a moment and welcome Colonel Grimm and introduce her very quickly so that we can include her expertise in the conversation. So, thank you for being here, Colonel Grimm. Colonel Kathleen Grimm is a nurse by trade. She is currently serving as the Chief of Clinical Readiness Operations at the School of Aerospace Medicine, tongue-tied a little bit, for the Air Force, where she is responsible for the curriculum development. Her background includes outpatient pediatrics, flight nursing, ICU, and being deployed as a chief nurse in a flying squadron, which gives her a wealth of personal experience that drives her to give young nurses the tools to be resilient in the face of unimaginable situations. So, thank you for being here, Colonel Grimm. I will repeat our last question that Jeff was just answering for us, and that is to give us an example where you have witnessed the importance of partnership and collaboration in a project that solved a complex problem that addressed crisis situations. So Dr. Dodds, do you want to follow up with?
Yes, yeah.
Thank you.
So we're still going through this crisis currently, but ways we're addressing, in family medicine and primary care, we have a significant issue with PPE. So a lot of the PPE that's being dispersed across the country is going to the hospitals, rightfully so, because those patients are more sick, there's a greater need. But in the meantime, it leaves us with scarcity of PPE. So at the beginning of the pandemic, we realized that this was going to be an ongoing issue, and it was imperative to find ways to protect our employees. One way this was done is multiple science and tech teachers around here got together at the beginning of the pandemic, and we connected with them. They developed a coalition to print 3D printed face shields. That's these here, like these. And they ended up working very diligently and sourcing PPE supplies. We have 100 face shields thanks to them. It takes about, and just to understand the level of work that went into, is people at their home school districts printed these shields, and then they came together at Southern State Community College in Hillsborough and spent hours sanding those shields, assembling shields, getting them to different healthcare facilities. They produced 4,000 face shields in the process of doing that at the beginning of the pandemic. It takes about 9 hours to print 4 of them. Wow. So while that might not be the most efficient way, it was at least one way we were really helped by it. And so that was one way. The other thing that happened is Dr. Kate Conway, who's a physician and on faculty at the Boonshoff School of Medicine and Family Medicine here, has had like a 12-year connection since she was in residency with Mercado Global, which is a United States-based company that they do their manufacturing in Guatemala. They work with indigenous rural women in the Guatemalan communities. And at the time they were helping source, purses and things like that. But they switched to face mask making. And because they've had so many global health trips there and such a long-term connection, they sent us 200 masks that were made there. Mercado Global has worked with the women of Guatemala. And in the time of this pandemic, they have produced, I believe the number is 85,000 face masks that they've sewed. It employs 750 indigenous women in Guatemala that feeds 5,000 of their family members. It's a significant contribution to their economy there, but yet they're helping serve our country and not just their own communities by giving back in such a generous way. But it was because of that, she built that long-term collaboration connection. They've done global health trips with medical students, and it started when she was a resident. Just in the same way, if we build connections among business, among military, among our practices, and work together, we can help each other in crisis.
Colonel Grimm, would you like to jump in with answering that question?
Sure. So the one example that I have from my career is the collaboration between the Air Force, DOD, and our civilian partners in developing the transport isolation system for the movement. It was planned for the movement of Ebola patients back in 2012 timeframe. A 6-month project from kind of the napkin thought process drawing to having a system that was considered safe to fly on the back of an aircraft, which is huge to have it done that quickly. But we partnered with a small business. We had representatives from the aircraft maintenance community to make sure that we weren't disinfecting the aircraft with something that was going to damage it. folks with the flying community to make sure that we could get it care for the patients inside the apparatus. And we're seeing it now being used, has been used for the movement of the COVID-19 patients out of various theaters, getting them back to care that's more appropriate than a field hospital, and then upgrading it to a different system. But seeing that we can better the process and better the piece of equipment that we're moving patients in.
Okay. Briefly before we all joined this conversation, we started talking a little bit about this next question, so I'd like to throw it out there. And that question is, what technologies in other fields or industries would you reach out and grab if possibilities were endless? Who do you think you could partner with to make that a reality? Who would like to jump in?
Dr. Dodds has a great one, so
Yes.
she absolutely should go first.
Well, we are, and probably most of us are that's in healthcare, we're using a lot of telemedicine, and we're still using a lot of telemedicine. I think it's here to stay. But one of the things I have found when I do my exam of my patient, I can't listen to a heart, I can't listen to lungs. I am collecting a history on the patient. They're telling me what's going on, but the inability to do that, the risk of what we're missing in caring for our patients. So if I could partner with anyone in industry and technology was limitless, we need a home delivery system that takes something into the home where we can listen to the heart, to the lungs, collect vital signs. If Amazon Prime can deliver something in 24 hours, why can't we do this to improve the quality of the patient care that we are providing? And that way, I think that would be a huge step forward in improving telemedicine. Because I think right now we're all on the same page. If you're in primary care and you're doing it, there's not much of an exam being done besides you just eyeball the patient like we're seeing each other right now. This is the limit of my exam.
And you can even do good marketing on vital blocks or something like that.
Yes. But that's like my dream technology.
All right, I love it. And for those of you that are listening and watching and preparing your questions as well, we've got some great ideas being put forth here. So let's get in touch let's brainstorm. Let's get in touch. Let's make this stuff happen. That's why we're coming together today. Jeff and Colonel Grimm, what about you? What have you got for ideas and to address these issues if possibilities were endless?
So it's been a long time since I've actually had contact with an electronic medical record, but that is just ripe for disruption, in my opinion, in my experience. If you just look at the technologies that things like Slack and Google and Basecamp and others have brought to the table, even like Trello, being able to manage small tasks and knock them off, and then extending that into remote monitoring. Everybody has a mobile device these days pretty much. Can you reduce the cost of smartwatches to be effectively your vital collector in a consistent and reliable way? I think there's just a ton of opportunity in that space to completely disrupt the EMR market. The challenge with that is the EMR market is essentially held down by two major players, and to dislodge a large competitor like that, you're going to have to be backed by a lot of money or a partner with Google or someone.
I think leveraging communication pieces and the telehealth piece is awesome for what we're doing with our outpatient care. Taking that onto the back of an aircraft or into another austere environment where I could have face-to-face or at least not play telephone and have to go through the pilot radio system to another pilot to the ground and finally reach a medical person to get advice or share information with. That would be my dream.
It could be a similar technology, between military and civilian healthcare that we'd be
right. It just can't interfere with the operating of the aircraft.
Right.
It adds a little a little challenge in there.
Oh, yeah.
So I love the brainstorming and the big ideas, and I hear a lot about sensors and how do we get this information that from a remote location to the clinician. And right now on this panel we have representations from the military, industry, and civilian practice. So Jeff, you touched on some of the stress or some of the roadblocks, but how could we reach out from different corners, different sectors to advance this personnel readiness, resiliency, and performance?
For me, it generally comes back to context, right? Context is so important in design and making sure that you can deliver solutions that are actually helpful, particularly when you're introducing advanced technology. So I kind of flip that towards access. I think each of the roles that are represented here, providing access and awareness to technologists into the clinical world and vice versa, from clinicians into the technical world, I think that unlocks the art of the possible, because you really start to open up the innovations and the angles that perspectives that people see from. I think that's where the magic happens. Innovation is a contact sport. If you're not in the field with the people that are working and live in that context every day, you're just ripe for delivering another useless technology. So that's why we push really hard on deep understanding and context to be able to provide solutions that people can actually use and want to use.
I think shared experiences as well. That the military brings a different perspective of the experiences that we've had that translate to the civilian side. Trauma is trauma. It's hard to deal with no matter who you are and where you're practicing. Putting that into a spot where your resources are limited absolutely applies to the civilian sector as well. So being able to collaborate and have those conversations of how do you deal with, you name the challenge, in your location, in your situation, and how could we then apply those types of thoughts and how can we implement that for us?
Yeah, I think the Air Force brings a ton of nice edge cases too, right? So we talk about resiliency and predictability being a part of that. A lot of times the Air Force has no location, right? You're moving on the move doing medicine. And I think that's a tremendous edge case when you're starting to look at new capabilities, is how do you do this without a home, essentially? Mm-hmm. And I think that's a fantastic opportunity for some breakthroughs.
When I think about us collaborating together, events like this allow this to begin to happen. Whereas usually I'm just seeing patients every day. This is a little step out of the unknown and starting to learn from each other. Something I did before we had this meeting, though, I did a quick literature search because I just wanted an idea on the terminology we're using. I looked up personnel readiness, operational readiness. All of that literature is all related to military. And so what I find is that I think we need to have either one research, but also some translation of terminology to help us work better together. I even spoke with an HR expert here at our practice, and nowhere in HR did they use the term personnel readiness, operational readiness. We have emergency management planning. And so I think about, we need to translate some of that terminology to help us better work together. And that's one way that we could make a step forward, even in crisis, because ahead of time, we now are using similar terminology, or we're at least more educated about the terminology that each other use. That's going to help us work together in the long run. I mean, one of the things that produced anxiety about doing this was like personnel readiness. I've never heard anybody say personnel readiness here at family medicine. And I knew that was just after just a brief research that it was just a terminology issue. It's not that we're not doing it. It's not the same terminology we use, so it seemed like unfamiliar territory. And so I think we have to look at some of those issues and making connections from military to academic to healthcare to business. How can we develop some common terminologies or understandings that are going to help us to work together so that we have an understanding of what each other do? That's going to help us be more innovative in the long run if we want to work together to improve patient care or improve employee performance.
Yeah, and it's another one that Carl Grimm can probably resonate with too. During my military time, resiliency meant suicide prevention. It was synonymous during at least some portion of my time there. And now resiliency in the context of what we're talking about is much larger than that.
Yeah, Dr. Dodds, that's a really good point that you brought up. And so I'd like to hear from all of you. How do you think we address this common terminology? I mean, I'll be honest, I'm not in any of your fields, right? And so to prepare for today, I did a lot of terminology research. And I still, throughout the day, and I'm not done today, there will be some times where people say things that I don't know, right? And so it's important that I continue to ask those questions. But Dr. Dodds brings up a very good point. How do we move forward with creating this common terminology so that across these different fields, these different sectors, we can create common solutions?
I think it's through collaborative research activities, working collaboratively together on projects that, I guess from the patient care perspective of things, that improve the care of our patients, no matter what the population or where we will be taking care of them. But I think that also has to have a grassroots effort, like working with my medical assistants and nurses on the floor. They need to know what personnel readiness is for it to actually be applied. I think sometimes we do these things from the top down without realizing the people on the front lines face it every day. And if we start with learning terminology from the ground up, I think we will do better working together.
Yeah, it's not unique to this field either. As we've brought UI and UX and cognitive systems engineering together in Mile 2, they're saying a lot of the same things with a different lexicon. What we found is it's engagement and its effort and a willingness to change is what makes those kind of alignments successful and being able to build a common lexicon. It's kind of like a sports analogy too, right? There's only so many football routes that you can run, but depending on what team you're on, what do they call it? Is it an out or is it an X or what is it? It's just the effort to get aligned on what we mean when we say term X.
I think too, it's the having consistent communication, collaborating with one another and having that and being able to ask the question of, okay, what do you mean by whatever? And we see it within the Air Force. You have some medical entities are associated with the line side of the Air Force and not the medical side. And trying to communicate with pilots or whoever medical type things is a challenge. It's teaching them a new vocabulary. What do you mean by this? And how do you put it down so that it makes sense and they can communicate it to somebody else and you get what you need? But it's all about having those interactions and not being afraid to ask the question of, okay, what do you really mean by when you say that? Because this is what I'm thinking, and it doesn't make sense. My context is not making any sense with what you are saying. And being able to have those conversations, I think, is imperative.
So that's a good primer. I'd like to throw a shout out to Tech Warrior, which is an event that they have locally to bring technologists, practitioners, and a lot of times it has medical implications. That may be a fantastic opportunity for all of us that are local here to Dayton and even others who want to visit to kind of rally around some of these Tech Warrior events to get the consistency that you're talking about, Colonel Grimm. You get reps under your belt with the same teammates, you start to get a good alignment, and then you have your breakthroughs.
I hear a theme, not only in this panel conversation today, but throughout the day about this willingness to change. So this idea of empathy and listening and understanding that when we're dealing with complex problems, it isn't just my understanding, that there are many perspectives to take into consideration. And so exploring those possibilities where you can be in the room, right? And you can be in communication and in conversation with people that have a different perspective, a different vernacular, a different experience is so critical to getting a bigger picture of these complex problems. And I want to give a shout out to WBI for making these conversations happen today. I mean, we're getting people in conversation with one another that might not otherwise have been in the room. And so thank you. Shout out to them. We do have a few questions from the audience. So let me bring those up real quick. All right. We've got one from Amy Magnus. Her question is, I'm aware of the interest of the en route care team at the Human Performance Wing is keen to in-flight interventions. What other capabilities are you prioritizing? Have operational priorities changed since the start of the year? Sounds to me like that might be a question for you, Colonel Grimm.
Kind of sounds that way. We do have, our focus has changed a little bit. Not necessarily new work, but refocused of courses in development that we were in, and the principles of biocontainment care is one of those hot topics of things that are a little higher on the priority list at this point, a little more highlighted of, oh yeah, we really do need that class and need it quickly. So in being able to educate our nurses and technicians in caring for the infectious disease patient on the back of the aircraft is adding to, we've had a little bit in there, but not the focus that COVID-19 has definitely brought to the forefront over the last 6 months.
So maybe to generalize that question a little bit, Dr. Dodds and Jeff, how have you seen a pivot this year, and maybe some capabilities that you're prioritizing that's changed since last year?
Yeah, I mean, absolutely. Remote work has become a thing. The fact that we're all not in the same room was something none of us would have anticipated pre-March, right? So we've reprioritized communication. So making sure that collaboration is supported through the technologies that we're using or through our processes. So
looks like we may have lost Jeff for a moment. So Dr. Dodds, would you like to jump in?
Yeah, I think what I see is one
we need to know, no.
really
That's been a big shift.
reprioritizing
Important
the PPE.
analogies to
Go ahead, Dr. Dodds.
Like reprioritizing like PPE access. Telemedicine has been a huge pivot in healthcare, just period, because we weren't doing it. You know, I think things I've read about healthcare is that we're kind of one of the last to like be willing to consider telemedicine, that this was just very limited use and now it's everywhere. And so I think we're really pivoting on kind of how can we improve the care we're providing.
Jeff, did you want to finish? We lost you there for a moment.
Yeah, so learning self-control to not swear when Zoom doesn't do what it's supposed to do, and you don't know if they can hear you or not. I've had to learn a lot about self-control, but it's exactly those kind of things. How do you invest in the technology and the infrastructure and processes to be able to be effective when you have potentially unreliable systems? The other one's mental health. We've focused a ton on mental health. You don't have the natural transitions to your day anymore, right? Where you used to commute, where you used to grab coffee on the way, where you used to have downtime. The day is all intermixed. And so we've spent a lot of time talking about take breaks, go for a walk. That's work too. You know, find boundaries, make them and adhere to them. Otherwise, we're going to start to not be very resilient as people.
I think we can say clearly with patient care and even employee care that we have seen significant increases in depression, anxiety, just more and more patients. And the longer we're going through this, the more calls we're getting. We luckily have a behavioral health clinician on staff. And so then we connect her with those patients so that they can have some one-on-one care right in the moment. But I think the longer this goes, and I don't think we're through this in a year, I think it's a while, that we definitely need to keep developing mental health support for employees, for patients, we're just going to see more and more of it.
Yes, thank you. So we've got another question. This is from Dan Sands. How or who do I contact to share about available technology to assist with remote patient monitoring? And before you all answer, I would love to just go around, tell us how listeners, Dan and any others included, can contact you, how you can, maybe steer them and if to other partnerships, and then what kind of partnerships are you looking for? So that if there's anyone listening who didn't shout out and ask the question, but who might be working on something or researching something, what kind of partnerships are you looking for? So to repeat that, kind of your information, how people can get in contact with you, what kind of partnerships you're looking for.
Sure. For us, you can hit us at our info@mile2.us, and it's TWO spelled out. It's the NBA playoffs. So WBI is an important resource in this ecosystem. They are fantastic at playing point guard. So making sure the ball's getting where it needs to be, so someone can be effective and score. So I would absolutely use them as a facilitator for connecting ideas, connecting people, getting your technology introduced to other folks. As far as us, we started Mile 2. We said we wanted to work with cool people on cool things. So if it's sufficiently complex and interesting and going to have an impact, we're definitely interested in having that conversation.
Okay.
I mean, for us, if you email me at michelle.dodds@rightstatephysicians.org, I can forward to executives, administration. We're looking for ways to improve the care we're providing our patients, and I'll forward it to the right people who have the power to make those decisions.
I'm kind of right there with Dr. Dodds. The best way to contact me is via my email. It's kathleen.grimm@us.af.mil. And that's MIL, sorry. And I can, if I can't answer the questions, direct you to the right area that can. As far as partnerships, anything that has to do with the clinical readiness of our medics, whether it's nurses, physicians, medical technicians, respiratory therapists, kind of the whole gamut, preparing them and also providing them resiliency, creating that resiliency piece for them. That's what we're after right now.
Hey, thank you all. Thank you for answering those questions. We do have another question. This is from Amy Magnus. And the question is, I'd love to follow up on the nurse interactions. Could the Colonel talk about that a little bit more?
I'm not totally sure I understand the question.
That's all I have. A limitation of these remote interactions, right? I can't, reach out to Amy and say, Amy, could you clarify for us? So, so a great representation of how sometimes in these remote interactions, we're limited with the technology that we have, right? So, yeah, I guess I don't have any clarifying information.
Well, hopefully Amy will hop back on and give us a little more.
So we've got about 5 more minutes. Let's just talk for a minute about, we touched on this quite a bit about, I love Jeff's words of context matters, but it's really about, understanding the problem before we start throwing out solutions. And today has been great of really identifying some of those problems where technology and partnerships can really have an impact. So maybe just, for the last 5 minutes, let's just dream a little bit about how can we partner to address some of these really complex solutions.
So for me, and I don't know if it's partnership per se, I think it hits that line. reflective practitioners like Dr. Dodds, like it's obvious that she not only can do the work, but she thinks about the work a lot. She can step back and look at it from the abstract and not just her single frame of reference and say, collectively, these are kind of the challenge. I think for technologists in particular, that folks that can do that are gold. So if you look around your organizations and you see people that can manage both of those perspectives and communicate them well, get them connected to the people who can help be problem solvers, whether a technologist or whoever. Those are the magical connections. The folks that can do both are tremendous, and that's where you get your breakthroughs in my experience.
So we actually do have a follow-up, Colonel, from Amy. It was about how the focus switched after COVID-19. So you first talked about biocontainment, and the second item she mentioned was how nurses interact with COVID patients. So following up a little bit more on those nurse interactions and how the training has changed.
We've done more of it. So the biocontainment, moving patients in a biocontainer in the back of an aircraft was very focused to the Ebola patient, 5 years ago, and COVID hit, and we're like, all right, well, we need to take this and move it to a different infectious disease. And how do we train those folks that are doing that? So right now we're doing just-in-time training. So they go to a location and get trained on the biocontainment, how to get it on the plane, how to use it in the aircraft, how to wear extensive PPE and protect yourself from those patients. They spend a few days doing the training. We got tasked, USASAM did, to create a more formal training course for that. And we're in the infancy of that formal training development at this point. But continuing, as the Air Force continue, we can't leave our medics and our nurses without training appropriate to be able to care for the patients that they're getting. So we continue the just-in-time training as we're developing the formal course and moving in that direction. So it's just a different focus from the normal med-surg patients that we take care of into something that requires some additional level of knowledge and understanding to prevent yourself from becoming sick and sharing it with anybody else.
Okay, thank you. Just as we've got 2 more minutes, so just as a final wrapping up, I know we already let everyone know how they could get in contact with you and what kind of partnerships that you are looking for, and so thank you for that. I actually have a whole lot of things that I wrote down are like sweet spots. Innovation is a contact sport, and problem solving is addressing brittleness. And so all of these words and these conversations help to do that, get that common terminology. And so I want to thank each of you for being here today, to sharing your expertise and being willing to do, to create magical connections, to share with us not only your knowledge, your dreaming, but also the problems that currently exist, that willingness to change and to be open to new ideas. So thank you so much. I also want to thank WBI, I already did, but thank them again. This has been a great day to bring people together and to have these great conversations. We touched a little bit on telemedicine. Our next panel, which is going to be at 1:50, is going to be more in depth on telemedicine. And I would love for all 3 of you to dial in and maybe shoot me some of those questions at the end of the conversation. I think it's going to be great to create some additional collisions. And so with that, we're going to wrap up this panel conversation. Again, thank you for being here.
Thank you for
Thanks
having
the
me.
opportunity.